screening for providers at our Department of Health Services clinics. I don't want to take too much of everyone's time, but I wanted to briefly touch on some of our evaluation efforts that we have used to kind of measure success of our work. As I mentioned, we hosted 4 symposiums, and so at every symposium we did some evaluation of what is actually happening here in Los Angeles County as far as referring, screening, and how the program is administered. And so that was information for us to be able to use to help to provide technical support and assistance, but also help us to inform future symposiums that we may have to make sure that we're providing the resources and information that our providers need. We also do yearly coalition surveys to understand how this coalition is actually supporting its members, and are we actually able to accomplish our goals through our memberships. And we've also done a coalition network analysis, and this has been really instrumental in helping us to grow our network. Through the network analysis, we're able to see where we need to, how are people working together? Are they working positively together, or do we need to bring on other individuals? And this has also been a resource to help us to think about how we're going to engage members in the future, and has been a great resource as we're, kind of shifting the efforts of the coalition. Lastly, we have done evaluations of all of our funded partners. Under 1422, the first grant that we got, we had the opportunity to be able to fund various national diabetes prevention programs, and so we did some evaluation efforts of how certain components worked. How did the lifestyle coach improve retention to the program, and what type of resources may they need? And then we also did key informant interviews with those funded partners, and that was really to understand barriers and facilitators to implementing this program, so that when we did get the next round of grants, we can try and make sure that our tailored technical assistance is able to address some of those concerns. And so in this next round of funding, we're hoping to continue to publish some of our findings from the last grant, and develop a new framework for scaling the diabetes self-management program here in Los Angeles. Of course, we're going to continue to expand the National Diabetes Prevention Program by providing training and tailored technical assistance, and helping these individuals to develop the infrastructure for billing. We're going to continue to work to identify individuals where we can organizations where we can offer this full spectrum of care. Work with national partners to develop toolkits, resources such as protocols and pathways, and media and outreach materials. And we're going to continue to work with payers to keep building that case for coverage, because if we do not have access to dollars to cover these programs, we're not going to be able to get individuals into the programs that could benefit them. And then we're going to, of course, expand our coalition efforts. So thank you so much for your time.
So thank you for a great overview of your work. I was wondering, one of the emphasis on increasing scalability.
Yes.
And thank you. And so when you started out, you've showed some of the maps, and you could look at across the different spas in LA, and you have some areas that are sort of the food deserts and so forth. Have you, in some of the evaluation work you've been doing, are you looking at how much diffusion or uptake there is in some of these areas that have, as so far, really not shown much uptake of these kinds of programs. In other words, I got that you're among the willing, you're seeing some uptake, but can you speak to that just
Yeah, so that is some of the work that we're trying to do in this round of funding, because we were not able, we had to focus on a particular area, which was LA City for the first round. This time around, we're actually able to really get a sense of what is happening in those areas where there's, you know, complete deserts, and really understand, you know, what would it take to get people to engage in this program, what organizations are actually out there and can help with this process, and then, you know, just really think about how to develop some type of plan and infrastructure with key partnerships to be able to do that. And then we also do have a robust nutrition program within the Department of Public Health that is also working in a lot of these areas, and so partnering with them to identify areas where we can perhaps you know, work with some of the organizations around like food procurement policies or even farmers markets and things like that, because, you know, it is a whole spectrum of issues that is going to help people be successful in these programs. And so we're trying to work within the health department with other divisions to try to address some of those issues. Yes.
That was great. You've got quite a comprehensive attack on this problem, which certainly needs it. One of the questions I have is, you know, there are a lot of elements that we can try.
Mm-hmm.
And sometimes when we're resource constrained for a lot of reasons, it'd be nice if there were a way of looking at all the options that we can do and saying, are there 3 of the 40 that work best if we were to try to limit ourselves? Is there any way that you can or are trying to sort of sort that out at all? Like which are the better bang for your, I don't like buck, but better bang for your resource unit?
Yeah, and I think a lot of that falls into various buckets. You know, when we're thinking about program sustainability, the biggest bang on our buck is to actually train organizations to have these lifestyle coaches and to be able to have a master trainer to be able to grow their program. And so when we're looking at it as far as, you know, kind of building the core infrastructure for these programs, that is the best way for us to spend some dollars, some resources there. When you're thinking about also sustainability coverage, because we work with a lot of small CBOs, you know, a lot of these larger health systems have infrastructures in place, but with CBOs, they do not have those infrastructures in place. And so working with those small CBOs to, how do we help them to develop some type of billing infrastructure, whether that infrastructure is one that they're building themselves, where they're developing, you know, kind of data systems and things to track the folks that are coming in, or partnering with a third-party integrator or a pair that can help them to develop that infrastructure. Ideally, we would like to have folks that are able to build that infrastructure themselves, but because a lot of the health plans are partnering with a third-party payer, then it makes sense for us to help them to develop that relationship, cultivate that relationship, and help them to develop those data portals. And so, you know, those are some of the things that we're trying to do. We did provide seed funding initially as part of the 1422 effort, and although it was fruitful for us to do that initially because we wanted to grow the program. Over time, it doesn't work. What really works is to help them to build that infrastructure, because you're only giving them $10,000 here and maybe $90,000 there, and that will last you a year, and then you don't have anything else. So really working on that infrastructure building, I think, is really what we're trying to do and continue to do in the next round of this grant.
Teach a man to fish. The other question I have is, You have some evaluation measures
Yes.
for your participation in the weight loss, et cetera. Probably challenging and depends a lot on your partners, but do you foresee doing any clinical outcome kind of data collection? You know, getting into the hemoglobin A1Cs or
Yes. As I said, for this particular new grant, I hate to talk about these two different pots, but a lot of the work that we're doing is really focusing on those health system strategies, and we're going to be looking at a lot of the EMR data, looking at all of the dashboarding, and looking and seeing how folks are actually going through the program, and are these individuals seeing improvement over time. So the goal is to do some of that work as part of our efforts under 1817. Thank you.
Dr. Emmons?
I just mentioned, I'm glad that we had this chance to talk beforehand. On one of your slides, I did not see an organization that's here. That's the Watts Health Center. And so we have two individuals here from the Watts Health Center. One is on the panel, we'll be talking in a second. But one of the things, I guess a comment more than a question. The value of this meeting is to introduce people.
Yes.
And I want to make sure you continue to talk with Dr. Brooks and Dr. Seamster in the back there too. And we didn't go around and introduce ourselves, but Dr. Seamster is a CEO of Watts Health Center, and I wanted to make sure Dr. Seamster was recognized here also, and that you could partner with this organization.
Yes.
I think that another slide you talked about improving clinical data. I think they have the opportunity, and I would love to see them participating in developing your research from a clinical and outcome standpoint.
Yes.
Wonderful. And I wonder if Dr. Brooks and Dr. Seamster could comment a bit on your presentation, ask questions. We were going to put that whole commentary section after the next speaker, but I think it's appropriate now. Just it flows better. So one aspect I'd like you to draw out, if you could, is your work with the faith-based community in the hardest hit areas, which we've found to be really, really important in other regions.
Yes. And so, again, because I have to limit everything to pre-1817, which was larger scale, and 1422, because we were very focused in LA City, because that was our deliverables and we had to report the data, we partnered with organizations, DPP organizations that had worked predominantly with the faith-based community. So, as I said, we did provide seed funding. We provided seed funding, and I didn't go into detail in my presentation because I just wanted to provide a larger overview. But in 1422, we provided seed funding to 8 organizations.
So just because we don't think in terms of grant numbers, can you just say, our previous grant that was focused on the city, blah, blah, blah.
Yes.
And,
And so
genericize
that particular, those particular groups, 2 of which, Black Women for Wellness and A Vision of Health, had been in the working on diabetes prevention for over 10 years and had great relationship with their faith-based community. They were already at the churches. They were already had great relationships with these groups. We partnered with them and provided them funding to be able to grow and to continue to offer those programs in their areas. And so that is what we did to try and, kind of like reach that particular group.
So that was the
Previous.
prior grant,
Yes.
and in this
In
grant?
this grant, we cannot fund organizations to do diabetes prevention work. And so what we will be doing is continuing to provide support to these organizations by helping them to build their billing infrastructure. And so with the billing infrastructure, they're going to be able to still provide these programs because they can bill, the third-party payer to do this work. If they are starting a new program, there is potential for us to do that, but but we're a little unclear on whether it's a new program, new organization, or a new site. And so once we get clarification from the CDC, we're able to really focus on like, okay, Black Women for Wellness would like to work in Antelope Valley with this particular faith-based group, then we can provide funding for that. But we just received that fund, so we're still unclear, and a lot of that guidance is still coming to us. Yeah.
I just have a question about participation.
Yes.
Did you track how many people went through the DPP program? And did you have totals, and did you have goals set around that, and did you achieve them?
Yes, we only tracked those organizations that we funded as part of our efforts, and we did have benchmarks which we provided them. So this organization is to enroll 100 different individuals into the program, and so we tracked each of those organizations' enrollment to see how they did. It varied. We had some organizations that had 100% enrollment in nutrition and were able to get all those folks through the program. And then we had a lot of groups that started with about 18 per cohort and only 4 completed the program. And a lot of that has to do with, the lifestyle coaches and the capacity of the organization, because it does take a lot of work to be able to, follow up with these individuals and make sure that they're going to makeup classes and things like that. So it just really depended on the organization and their capacity to be able to follow these individuals over time. And so that was some of the data that we collected through those key informant interviews and through the data share agreements that we got.
So did you have a total of how many went through the whole program?
So as far as the totals of for the eight organizations that we funded, about 620 people went through the program.
Dr. Brooks has a question, and then we can go with Janina, and then we'll go back to Norm, and then, yeah.
Thank you. Excellent presentation, Dr. Vogt. So 1422 had seemingly more monies to go out to organizations,
Yes.
and the new grant doesn't. So at Watts, we have diabetes registry, we have in-house podiatry, optometry, we have certified diabetes health educators. We have some of the infrastructure that maybe would be helpful, I believe, in the second grant. We do classes for LA Care, Boyle Heights, East LA, and Linwood, so we already are doing the outreach. So I guess the question would be, would our site be one of those that you would, in fact, consider reaching out to in the second, as you say, support? It would be helpful, I will say, if we can bill. I mean, we are billing some, but there are challenges, as you know, in figuring out exactly how to bill properly for what service you're giving, who to bill. I think that this second grant, although it doesn't seem like it has much funding, could still work if you find organizations that are close and just need to cross the Rubicon. You can take us to the next level.
Yeah, and we can definitely help and support, and if there are, once we know the full guidance and how we're able to fund, then we can, definitely see how we can work with organizations to provide, what we like to call seed funding. But yes, and it's, for us, it's great to come to these types of meetings, because this is where we meet a lot of the folks that are doing the work, because we don't often have the opportunity to go out and meet some of the organizations. So yes, I would love to continue this conversation and see if we can work together.
So we're happy to have Janina Morrison, Medical Director with LA Public Health with us. Welcome back, Janina.
Thank you. So I work very closely with Jennifer, she's one of my idols. And I just wanted to comment, so I sort of sit in an interesting place where I work with her at Public Health, but I also work for Department of Health Services. I'm a primary care physician at UCLA Medical Center. And so I sort of straddle this world between public health and health services. But the really unique part of my job is that I work for a community-based organization called the Wellness Center that's on the campus of the county hospital, where we offer these programs. And full disclosure, before I became the medical director of the Wellness Center, I had never heard of these programs. I missed them in all of my training in medicine, in primary care, and public health. I learned about them through a community-based organization, and I said, oh my gosh, this is what I need. I don't have tools to facilitate lifestyle modification. I'm just going around in circles with my patients in the clinic, and these are evidence-based, extremely effective programs. Now, that does not make them easy to get your patients into. It is really hard, but we've had a lot of success at the Wellness Center with using navigators to get people into these programs and to help them. It's just so hard to figure out, like, is it the right time of the week, and is it near my office, or is it near my home, and is there childcare so they can go, you know, I have my grandkids that day, blah, blah, blah. So the one thing I wanted to add is that I'm now working to help the Public Health Department and Department of Health Services figure out how to roll this out more widely. And one of the areas of tension that I think we all feel in the healthcare systems is, do we just run these programs ourselves in the clinic? Like, do we take a community health worker, a promotora, a health educator, get them certified to run these programs, and we'll just have them in the conference room that we have, or we'll have them in the little classroom? Or do we try to partner with a community-based organization that's offering them in a church or in a YMCA? And I think the answer is, at least the answer for LAC-USC is, it's both. There's some patients who they're never gonna go anywhere except their clinic. That's the only place they can ever find, and their lives are too complicated, and so they'll just get an appointment and they'll show up at the clinic or somewhere on campus. And then there's some people who they'll come at the clinic, and then it'll just never click that this actually has to translate into how they behave normally. So they can come to the clinic and tell you, I'm gonna do this, I'm gonna do that, but the reality is they have to change how they eat, they have to exercise more, and that's actually more likely to happen if this happens at like the rec center, where then they can keep coming back, so they have somewhere to go where they can keep getting exercise, and they're not just seeing this as a time-limited intervention. So it's really interesting to think about how to make this sustainable and affordable, and one of the things I'm a big proponent of, which some health insurance partners have started to do, is bundling this with other sort of incentives, like slightly more fun services. So at the Wellness Center, what we do is we really try to get people into evidence-based programs, but if they're not really into it, in the beginning we say, okay, why don't you go to a cooking class? I mean, like, everyone wants to go to a cooking class, like, you get free food, and the cooking classes are all taught by like public health informed, you know, so they're healthy. And then while they're at the cooking class, they hear again about the evidence-based programs. Okay, if you really want to make a change with your weight, you're going to have to do one of these programs. But then people sort of get in because they're coming for something fun, and then we pair it with produce distribution. So people are coming in and then they're going home with 2 bags of fresh produce. And so it's just this sustainable thing. So while they're not ready for the program, they've got somewhere to go. Then when they finish the program, they've got somewhere to go, because they can keep coming back for the cooking class, which kind of reminds them, gives them new recipes, or they could just keep coming back for the produce distribution, which addresses the food insecurity, which is a huge contributor to diabetes and prediabetes. So, and then, I mean, I can go on and on, because the reality is when people do these programs, things come up about, you know, mental health, they need access to mental health services, they need access to housing security services, so we do end up bundling a lot of social services together, just in offering these lifestyle modifications, but I really encourage those of us in health systems and payers to think about how to bundle these, so we're not just paying for the diabetes prevention program, but also things that make it actually interesting and patients get excited about coming.
It's a great point about incentives, thank you. We are now going to switch in our program to the portion about the new science that we can use, deploy to better help our diabetic patients. So with that, Dr. Carol Zaher from HealthNet is going to introduce our Dr. Norm Lepor. Very interesting long connection there.
Don't say long. No,
Say how long.
don't say how
You'll be
long.
more embarrassed.
That's right, I'm a little bit longer than that, too. Yes, it's my pleasure to introduce our next speaker, Dr. Norman Lepor. I've known from our mutual training at Cedars-Sinai. Norm has, if you look at his bio, you will see a long list of accomplishments. I don't want to take up time doing all those, but let's just say he spans the clinical, academic, and research realm of cardiology. And his topic today is innovations in care of the diabetic patients, which I will say, when I did train long ago, diabetes was basically in the purview of the internist, PCP, and the endocrinologist. We cardiologists like to do other things. But it now behooves us, since obviously a lot of the complications are in our realm, to really take a better approach more holistically, and I think Norm will verify that in this talk.
Yes, so Carol and I, again, I won't say how far back we go, but when I was a resident, Carol was one of the fellows, and I always looked up to, actually, even though I looked down, I looked up to Carol. So, and I still do.
You got taller and I got shorter.
And I still do, because she certainly was one of the fellows that I was learned so much from. So with that, you can say, here's my topic, diabetes and cardiovascular disease, a not so sweet connection. Did I say that, or did you guys say that?
That was you. That was you.
That was me. Sometimes I make these
It was late
presentations.
night.
For those who know me, you get emails at 2 o'clock in the morning. So perhaps it was some hour that wasn't
Low blood sugar.
as clear. So you might say, like, what the hell is a cardiologist talking about diabetes? And it's a great question, and until about 3 years ago, there really wasn't much for a cardiologist to talk about, because all of the treatment algorithms we had for the treatment of diabetes, which is why the prevention is so important, but none of the treatments we had for diabetes that lowered glucose, that lowered A1C levels, actually led to any change in terms of what we call macrovascular events. So it did not change the incidence of heart attack, stroke, cardiovascular mortality. And what my endocrinology colleagues do tell me is, okay, Lepor, that's okay, but we still need A1C because there's what we call microvascular disease, such as retinopathy, nephropathy, neuropathy. But as a cardiologist, I care a lot more about macrovascular disease, and therefore I've become a bit less A1C centric. And with these 2 new groups of therapies, which I'll talk about, the SGLT2 inhibitors and the glucagon-like peptide receptor agonist, we now have 2 therapies which actually reduce cardiovascular events, which is why I think this is a great entree for cardiologists, and why I certainly am very assertive as I travel around the world, actually, to deal with this issue, to really have cardiologists treat diabetics with these compounds, because our goal is risk reduction and reducing cardiovascular events, and therefore, in my mind, having the cardiologist more deeply involved in the care of these patients, particularly with these new therapies, would be akin to what they would do with statins and with blood pressure medicines. So we look actually at endocrinologists and the primary care physicians as partners, but cardiologists perhaps are a bit more assertive in terms of their approach to things, and so therefore, it's been an easy entree for me. All right, so let's get into the topic. So what we're going to do is really spend a little bit of time just reviewing issues of prevalence, talking about the disease state, current formulary, talk about the key clinical trials that have really brought these two classes of compounds to the forefront to update the ADA, the most recent ADA